Так, меня не включили. I'm not part of the translation right now. Can you do me as a translator? I'm just a panelist.
Okay, Irina, just 1 second. It takes time
Mhm.
sometimes to.
Welcome, everyone. Just give us 1 minute to allow other people to join. Okay, let's get started. Good morning, good afternoon, and good evening, everyone. Welcome to our webinar today on the assessment and brief intervention of suicidality and self-harm with adolescents by Dr. Atasuntseva. My name is Antonio Harden. I'm the director of the Child Psychiatry Division here at Stanford. As some of you are aware, we've been doing webinars for about 7 months now. And if you go to our webpage, you will be able to see the previous topics that we covered. We have one more presentation for 2022, and it will be done by Dr. Lauren Moskowitz, and she will be talking about treating fear and anxiety in youth with autism. We will be posting on our website the dates and the name of the speakers for 2023, and these presentations will take place either the first or the second Wednesday of every month. Before we get started, I just want to remind everyone that we have evaluation that will be sent to everyone regarding this webinar, so you can provide us feedback on the content, but also suggestions about future topic. The topics that we will be bringing on or will be focusing on in 2023 were all suggested by all of you. I want to thank Irina and Dimitri for making sure that we have interpretation today in Ukrainian and in Russian. And now I'd like to introduce Dr. Atasuntseva, who is a junior faculty here at Stanford University. She joined us about a year ago, and her expertise is in dialectical behavioral treatment, and she's currently working with adolescents with non-suicidal self-injury and suicidal behavior. She'll be talking on the assessment of suicidality and self-harm with adolescents, and she will be discussing a brief intervention about this topic. Without further ado, Dr. Atasuntseva.
Thank you, Dr. Harden. I really appreciate the opportunity to be here and just these wonderful series of talks that yourself and everyone has put on. Hello, everyone. Здравствуйте все. Меня зовут Анаид Атасунцева. Я психолог тут в Стэнфорде. Сегодня лекция будет по-английски, но я разговариваю по-русски. I will be giving this lecture in English. However, I do speak Russian. If there are any questions or anything, I can answer in the end in Russian. I'm going to go ahead and pull up my slides. Hopefully everyone can see those all right. Okay. So as Dr. Harden mentioned, today's talk will be on the suicide risk assessment in adolescents and brief intervention. So a little bit about me. In addition to specializing in DBT and the assessment and treatment of suicidality and non-suicidal self-injury, formerly known as self-harm, I'm a clinical instructor and junior faculty here at Stanford, and have actually some level of expertise in working with mental health and mental illness with people from Ukraine and from Russia, actually. And a lot of my research during graduate school was looking essentially at attitudes and perceptions towards mental health among individuals from several countries from the former Soviet Union. However, the mass majority of my participants were from Ukraine. And as I just mentioned, I am fluent in Russian, and I understand and am learning much more Ukrainian, which is a goal of mine. So really love that we have the slides in Ukrainian so I can look over them as well. So today, we're really going to be focusing predominantly on how you assess suicidal behavior, and then I will be overviewing a short intervention for suicidality and non-suicidal self-injury that we've been piloting here at Stanford. And then we'll spend a lot more time speaking about lethal means restrictions, safety planning, and how to reduce conflict within the home, and as well as contagion, which we know are huge risk factors for increasing the likelihood of suicide and increasing the likelihood of non-suicidal self-injury. I'll speak a little bit about some volunteer services that I've been a part of and some lessons learned around treating suicidality and self-harm in youth. And then we will break for any questions. So first, I just wanted to spend a little bit of time clarifying the definitions around exactly what we mean when we talk about a suicide attempt or self-harm, because these topics have really, and with the research in the last 10, 15 years, our definitions have really been shifting and changing. And I just want to make sure we are all on sort of the same page. So for suicide attempt, we really are discussing a potentially self-injurious behavior that's associated with some intent to die. So it's an action with the intent to end your own life that actually has the possibility of ending one's own life, or at least providing grave injury to someone. And really important here is this intent to die versus non-suicidal self-injury, which some people used to more broadly call self-harm, is the idea of self-injurious behavior that's not associated with the intent to die, and really is around this more an intent to relieve stress or communicate distress to another person, or sometimes based out of things like guilt or wanting to punish oneself. So common methods of non-suicidal self-injury that you may be familiar with or have heard of are things like cutting or burning or engaging in other forms of injury to the body that are not predominantly with the intent to end one's own life. We really discuss self-harm actually as the broader category of all intentional self-injury, regardless of whether there was an intent to die or not an intent to die. So really self-harm encompasses both suicide attempts as well as non-suicidal self-injury or NSSI. So I just wanted to clarify those points a bit. Okay. So within the assessment of suicidal behavior, there are sort of a few main categories that are particularly important to discuss, and really for, if you are clinicians, for clinicians to address. First is the overarching category of suicidal ideation. So what we mean by this is thoughts about wanting to be dead, or thoughts about not wanting to be around anymore, or thoughts about wishing you could pause your life and not turn it back on, are sort of all this kinds of thinking or speaking that we would address to passive suicidal ideation, versus active suicidal ideation is really expressing a desire to kill oneself or end one's own life. So really much more this passive thinking of, I wish I might be dead, but not as interested in maybe killing oneself, versus an active sort of not even planned, but it's just an active thought that I would like to be the one to end one's own life. Or and then going into the second category, at times a plan does come along. So it's particularly thinking about a method of suicide. So considering different methods, or really picking one method that you may be interested in using to end one's own life. So thinking that I am going to end my own life by, cutting my wrists so that I bleed out, or taking medications to overdose. So having a specific plan of how you might end one's own life identified is really when a plan comes in. And sometimes there are sort of preparatory actions taken, which we really describe as taking any preparations towards your plan. So for example, if a teen has an identified plan to end their own life by taking medications, have they begun to research on the internet what the dose of this medication is going to be required in order to end their own life? Have they actually started to look for the medication? Do they have the medication in hand? Are they hoarding or hiding medications pill by pill to make sure that they have what they need to carry out their plan to end their own life, for example? So it's really taking identified steps to end one's own life. If they are thinking, have they identified a specific bridge or a route they can take? So, really asking when you are, as the clinicians assessing this, really asking not only is there a plan, but also there been steps towards the plan. I think sometimes what is tricky in doing suicide risk assessment, particularly with teenagers, is that there may be this temptation to ask, like, have you any idea what you might do to end one's own life? I think this can lead you in a complicated place, as teenagers will start to sometimes they'd be like, okay, well, I've had these thoughts of like, well, maybe I could die by strangulation, or maybe I could jump off of a tall building, but there isn't sort of a specific or committed plan that they have. Or rather, they've had maybe some intrusive thoughts about ways they may end their own life, but they don't have a specific plan, as they have picked out one way to do it. They have started to identify means they could use to do it. They've maybe even planned out a specific date or something like that. So being very careful in your questioning to make sure you're truly assessing if there's a plan, not just maybe some intrusive thoughts or things that the teenagers may have vaguely thought of. So that is definitely important to still know if they're considering a lot of different methods, but it sort of is different in the severity of risk versus a teenager that is identified, there is a railroad crossing a mile from my house, and I know my parents aren't home on Thursdays at 6 o'clock, and that is a time that I could go to this railroad crossing to end my own life. That's a very different picture than a teenager, for example, that is considering many different ways that they could end their own life. And then the next largest category, and one that is particularly important when assessing youth, particularly teenagers, is whether or not there's intent to actually attempt suicide or to end their own life. So it is very important to assess intent. Is this something that they plan to carry out? What is the strength of their intent? Oftentimes with younger kids, with teenagers and younger youth, even more important than the specific lethality or how likelihood their method is to end their life, what is important is how strong their intent is. So if they truly believe that a specific method will end their life, and they really, really want to use that method to end their life, then even if that method isn't necessarily very lethal from a psychiatric perspective, that is very concerning, because they might move on to a different method, especially when we're working with younger adolescents. It can be very complicated in that they may not know the lethality of certain methods, and maybe choosing methods that to you as the provider, you're like, okay, that's actually not going to end their own life. However, the fact that they have that intent and maybe are making plans or even considering a method at all is very serious and really marks a need for intervention. Especially suicidal teens, they may start out with one plan that may not be as lethal, but move on. So being very careful to assess for the intent is what's critical here. Then there's the ability to commit to safety or a safety plan. So we don't sort of have teenagers contract for safety or say like, I'm definitely not going to self-harm. I'm not going to have a suicide attempt, because that is typically not effective. What is effective is to really assess their willingness to use a safety plan. And we will go through later in this lecture how to create a safety plan, but really assessing, are they willing to try and use skills or contact someone? Or if you are lucky enough like me to be a DBT therapist and have access to phone coaching and be able to talk to your patients 24/7, are they willing to call you as the provider to help them use a more effective skill? And then thinking about the existing risk factors that are around in this teen's life. So we will go through some of the potential risk factors in a little bit, but really thinking about, sort of what is maybe making the likelihood for suicide risk more intense as far as sleep or family conflict or other mental health issues. And then finally, was there a prompting event? Typically speaking, suicide attempts are typically the result of an underlying risk factor combined with a prompting event. The prompting event, or what really caused the teen to go through with their plan or act on the suicidal ideation, may not be entirely clear right at the start. So it's very important to do a really, really thorough assessment of what were they doing? What were they thinking? What was going on sort of right before they had the suicide attempt and every step of the way until they decided to actually follow through with their attempt. And there may be vulnerabilities or sort of larger prompting events or triggers that happen on earlier in the day, like they got in a fight with their parents, or there was a bad test grade, or they broke up with a significant other, or they're having a fight with their friend. And that might not be the prompting event directly for the suicide attempt in the moment. It likely might be a thought or a feeling or something different. So being very careful to assess what happened exactly before the attempt that led to the suicide attempt. And then finally, really assessing the safety of the home environment and the abilities for parents to monitor the child's safety. As we will see as we go through this talk, working with adolescents does require us to lean very heavily on the parents or family members or whoever is involved in the teen's life in order to help keep the teen safe and help provide monitoring. And as the next point makes, help remove access to lethal means. Teenagers, many people, but particularly youth, are very, very impulsive. And so we will go over this in great detail, but doing everything we can to remove access to lethal means to give them a bit more time to calm down or use a skill is imperative in reducing the likelihood that they will actually follow through with this suicide attempt because they don't have anything that they can use to act. All right. Moving on, as I mentioned, there are several risk factors for suicide, and it's very important to assess these. Do they have a past history of suicide attempts? We know that the likelihood to attempt again is much greater if you have a past suicide attempt. Do they have a history of non-suicidal self-injury? It used to be considered that teens engaging in non-suicidal self-injury, such as cutting, may actually not have suicidal ideation. However, there's been a wealth of research now to show that this is indeed not the case. Actually, suicidal ideation often precedes non-suicidal self-injury by a year. So what this really means is that teens are likely to be considering not wanting to be alive or even considering ways to end their own life for about a year before they start engaging in NSSI behaviors such as cutting or burning or something else. Then obviously, if there is sort of another mental illness on board, such as depression or substance use, or for males, conduct disorder, this can highly increase the likelihood of suicide and increase risk. Or if there's the tendency to be aggressive or violent or impulsive, this can really increase the risk. And as I mentioned earlier, impulsivity is a big factor to consider, as well as substance use or history of child abuse. Family conflict is something we'll be talking about a lot in today's lecture. And really, we know as clinicians, one of the most effective things we can do to reduce the likelihood of suicidal risk is to reduce conflict in the home. Feelings of hopelessness or a family history of suicide also increase risk. And looking out days ahead of the suicide attempt for severe insomnia, poor or difficult sleep, or severe agitation are also likely to increase the risk that a child may act on a plan. acute psychosis, bullying at school, being a sexual or gender minority, particularly if you're living in an environment that is not affirming to your gender or sexuality, highly increases the likelihood that you will engage in a suicide attempt. And another topic we'll be discussing heavily as we are speaking about teens today is this idea of contagion, or really seeing other people that you feel have similar demographics to you engage in non-suicidal self-injury or engage in other acts of self-harm like suicide attempts does increase your likelihood, and really you may see it more of as an option for yourself. And finally, precipitating events or triggering events that are strife with humiliation or feeling of shame or despair or loss of a relationship likely or often precede suicide attempts. So it is not all bad news. We do not just have risk factors for suicide. We actually have many protective factors as well. So, and this is something we do a lot in our brief interventions, is really assessing what the protective factors are and trying to increase them as much as we can. So looking for having a reason for living, large or small. I will ask kids what makes their life worth living, both in the short term and the long term, and I will describe to them as anything that they can come to mind, from big and small. So it can be something as small as the weather outside, or wanting to finish their favorite book, to something as large as their future goals, and wanting to be a teacher or a doctor or whatever they want to be, or their families or their religion. So really looking at everything in between that can really contribute to why they want to live. I'm a dialectical behavior therapist, and in DBT we talk about, we are not here to convince people to live a life that is miserable for them. We are really here to find what makes their life worth living and help them see why life is worth it. And I think it really starts with this assessment of protective factors. So do they have hope for the future? Do they have responsibility to someone, their friends, their family, particularly their pets is a strong one with youth that they do not want to abandon? Are they embedded in a social network, whether that be a family directly or a school network or a club or something that really is important to them? Do they have a fear of suicide, death, or dying? Definitely want to capitalize on any fears like that to really encourage them to seek treatment or use skills instead of engaging in self-harm more broadly. And really assessing for any religious beliefs that do not allow suicide, or any plans that they have for the future. So as many of you who are clinicians may know, there is not much we can do to accurately predict suicide attempts or death. Based on a more recent meta-analysis, really over the last 50 years, we know that professionals really are only better at predicting risk for suicide at about 50%, slightly better than chance, I should say. And we cannot predict it, and we do not have the power to completely prevent it. So I want to get that right off the bat. If you are hoping to come here for a magic solution or crystal ball on how you can tell if any of your patients are going to attempt suicide, I unfortunately do not have that power. No one has that power. And there may be no way to accurately predict who will attempt suicide, and doing a thorough risk assessment will give you a better sense of what how severely to intervene, when to intervene, and some of the intervention tools that I'm going to be discussing today can really help the individual choose to use skills or feel like they have alternatives when they're maybe feeling impulsive, and does reduce the risk of suicide, even if we cannot predict it. So while we cannot predict it, we can lower it, as the text in red says. So this is a question I get by lay people all the time. Why do people do it? Why, especially would a teenager that's in the prime of their life, make a suicide attempt? Well, suicide attempts are actually the cause of a very complex and underlying factors, combined typically with something that is going on in the present acutely. So Really, this is a combination of the risk factors we talked about, such as having significant mental illness, maybe being in a family system or other system that is in conflict, or another high conflict zone, like being in a war zone, for example, or having sort of severe insomnia. Many underlying factors can sort of put you at a predisposition for suicide risk. But it is that with the combination of something in the present that has gone on, sort of a prompting event that leads to suicide risk, or leads to suicide attempt. And really, these individuals, these teenagers, are under unbearable emotional pain. Their lives as they are currently being lived are incredibly painful. Marsha Linehan, who many of you may know, likes to give this metaphor that, being an individual that's considering suicide is like living like an emotional burn victim, with burns all over your entire body, where every single moment, every single thing anyone says to you is like having those wounds sort of opened, or like having burn wounds like meet the air. That is the level of painfulness. That is the level of pain that these individuals are having. And that, combined being within a situation that they find unbearable, or combined with the belief that they think things will never change, or feeling very hopeless or impulsive or struggling to solve the problem, can really lead to actually deciding to end your life. So we spent quite some time talking about suicide. So I want to go back to this idea of non-suicidal self-injury, which is sort of a bit separate from suicide. As I mentioned, while suicidal ideation often precedes NSSI, NSSI is frequently present also when people are having suicidal ideation. So when we talk about non-suicidal self-injury, what we're really talking about is methods that are intending to hurt yourself without the intention of dying. So this can include common methods like cutting, burning, scratching, or headbanging. So a very careful note, if you are a clinician and you are assessing with a patient whether or not they're engaging in NSSI, I caution you to not go through a list of activities and ask them, are you cutting? Are you burning? Are you scratching? Are you headbanging? Because you don't want to unduly or accidentally influence them to engage in behaviors that they're not already engaging in. While asking about suicide risk or self-harm generally does not increase the likelihood that someone will engage in NSSI or suicidality, we also don't want to maybe give them ideas specifically about self-harm. So what we're asking about are really specifically questions like, are you doing anything to harm yourself? Are you engaged in any self-harm? Teens are pretty much always know what we're talking about when we're talking about that, and we'll say yes or no. Or what I will ask them, they will say, I do self-harm, and then I will just simply ask them, how have you been injuring yourself, rather than offering methods, so that they can list for me what is exactly going on. So when you're engaging in this injury, as I mentioned, there's no intent to die. We in a different time in psychology used to sort of talked about these things as being suicide gestures or attention seeking. We really don't use that language anymore, in part because it is very stigmatizing and very judgmental and blaming, and we're really moving away from that and really embracing that for these people. Their lives are unbearable, and they are sort of seeking any answer to try and help themselves. And two, because it doesn't sort of get at what we know about the etiology of non-suicidal self-injury and the ways that it's upkept and reinforced very strongly through a number of different ways. We know that engaging in self-harm actually does reduce stress temporarily. It does lower heart rate. It does sort of have a lot of impact. So really, there is a function to their behavior. And for some people in the short term, it is effective. Again, it's not effective in the long term. Obviously, it can lead to significant injury and death, but really trying to be as non-judgmental as possible when you're discussing these topics. So treatment often involves determining what the function of the behavior is. So why are they engaging in non-suicidal self-injury? Is it because they're looking for a relief from some sort of stress? Is it for communication because they feel like they cannot adequately communicate the depths or severity of how they're feeling? Is it for punishment? And really looking for alternative things to replace it. So that is when a lot of skills or coping skills teaching comes in. I'll be sharing some of those skills from DBT at the end of this lecture. We generally do not hospitalize for non-suicidal self-injury. Really, the goal here is to remove the means that the teen is using and increase the level of supervision and really help the teen or anyone that's engaging in NSSI to find alternative coping strategies. And as I mentioned, common reasons that people engage in NSSI are like affect regulation to feel better, to avoid a pain, to reduce this feeling of dissociation. So what I mean by that is teens will frequently say to me, like, I just wanted to feel something. I felt nothing. I've been numb for days. I just wanted to feel something. So it's almost like a mindful practice for them, or they say it really like slows down their thoughts. That's the affect regulation part. Or sometimes it can be communication. Teens may say things like, I really wanted to be able to see on the outside just how much in pain and how much I'm struggling on the inside. Or it can be for self-punishment, especially when it is coupled with feelings of shame or guilt. Often there's a shame, like sort of self-punishment component attached. So as I mentioned earlier, non-suicidal self-injury is a predictor for suicide attempts among depressed youth. Adolescents often engage in both NSSI and suicidal behavior concurrently. So that what that means is they may be engaging in non-suicidal self-injury on some days and really planning or making suicide attempts on other days. Sometimes they may start out with the intention of just engaging in NSSI while cutting, and then the thought of an intent to end their own life comes up as they are mid-engaging in NSSI or mid-cutting. And really, it may serve as sort of the predominant theory right now is that it increases the risk for suicidal behavior because it sort of serves as a gateway to attempting suicide. So I like to clarify what this means. Really, the idea is the more you engage in self-harm like cutting, sort of the less scary the idea of suicide or death becomes. And we know that, as I mentioned earlier, suicidal ideation does predate the first non-suicidal self-injury, typically by almost about a year on average. So just a quick practice quiz. I know you guys are not able to write in the chat, so I'll give you a moment to think about this to yourselves. But if you are interviewing a teen who tells you that they have recently cut their wrist with a razor blade, to yourself, are you thinking that this is a suicide attempt or non-suicidal self-injury? So I'll give you a few moments to answer that question for yourself in your head, and then I will give you the answer. Okay. So it is actually a trick question. We have no idea if this is non-suicidal self-injury or a suicide attempt based on just the information given that they recently cut their wrist with a razor blade. What you are looking for to determine if it's just non-suicidal self-injury versus a suicide attempt is, was their intent to end their own life? So that would be my next follow-up question to this teen would be, did you sort of, what happened here? Were you trying to end your own life when you did this? Or was it for one of the previous factors that we had talked about as far as affect regulation, dissociation, interpersonal communication, or self-punishment? So it's really, really important to differentiate, was there or was there not intent to end their own life when they engaged in the cutting? So switching gears a little bit, I'm just going to check the Q&A real quick, but then we're going to switch gears to intervention. So I hope everyone feels like they have a pretty good sense of how to conduct a suicide risk assessment and the importance of looking for really the difference in intent for non-suicidal self-injury versus a suicide attempt. And now let's talk about what you can actually do. As some of you may know, really the gold standard treatment for individuals that are engaging in suicidality or non-suicidal self-injury, self-harm more broadly, is dialectical behavior therapy. So DBT is typically a 6-month program that includes for teens, a multifamily skills group where they learn skills to regulate their emotions and help with interpersonal communication and how to, in the long run, accumulate positives in their life. And in addition to a skills group, it includes individual therapy and access to a therapist, a DBT therapist 24/7 for phone coaching. However, this is intensively a really intense program that is not available in many parts of the world and not available in many parts of the US and requires a lot of training on the basis of the therapist. And while it is excellent and does work and is the gold standard treatment for suicidality and self-harm, we are always looking for ways to sort of adapt it in order to provide a bit more support for clinicians and what they can do in order to reduce risk. So here at Stanford, we have been running something called the Adolescent Safety Assessment Program, or ASAP Clinic, for I believe about the last 5 years, for families and youth who are seeking outpatient services and are presenting with suicidality or self-harm. We meet with these families for a max of 4 sessions. And really what we are doing in these families is we are assisting them to linkage to other services. So we are really helping them get the care that they need, as it is often really difficult to find adequate or even available mental health care. And more importantly, or maybe not more importantly, but just as importantly, we are really focusing on safety planning and helping, which we'll go over the interventions next, but safety planning and reducing suicidal risk factors. And this intervention really is DBT informed and uses a lot of DBT skills to support it. And something I think that is more easily transferable. So first and foremost, when teens arrive to the ASAP clinic after we do an assessment with them and their families, we are looking at really doing a number of safety procedures to decrease the risk. First and foremost, we're talking about removal of lethal means. So we will go into this in much more detail, but removing anything that the teen could possibly use to end their own life. Increasing parental monitoring of the patient, so making sure that the parents and family understood to keep a very close eye on their teen. So this can really range from having sort of a door open policy where parents are just checking in on the teen every 5 to 15 minutes just by peeking in their room to make sure they're being safe, to much more extreme measures such as 24/7 supervision, which means really sleeping in the same room as the teen, not allowing the teen to use the restroom without the door cracked or things like that if they are in a period of acute distress and suicide and cannot be hospitalization is maybe not an option or not appropriate in that moment. And then writing a written safety plan, which we will discuss, and really increasing the frequency of contact with a therapist if there is a therapist on board, or getting the teen connected to a therapist if there is not a therapist on board. And as always, considering whether or not hospitalization is needed for this child at this time. And we will kind of discuss how to decide that. So when we talk about the removal of lethal means, which is sort of the first part in our safety procedures, as I mentioned, it is incredibly important from my perspective and from the perspective of many people that work with youth with suicidality to really remove as much as possible that they can use to end their own life, because it decreases the possibility that they're going to act impulsively. As I mentioned earlier, teenagers are very, very impulsive. Just by their biological nature, and especially individuals who are maybe suffering from depression or other mental health issues also have an increased risk for impulsivity. And if they have emotion dysregulation, and really oftentimes something that happens may trigger the likelihood that they will engage in a suicide attempt. And if we can just create some time, some space between the time that the thought or idea or plan comes on that I'm going to act on ending my own life right now, and the time that they actually have access and can get whatever they need to end their own life, such as pills or sharps, then in that time and space, then the emotion can naturally go down on its own and the teen can decide to act. Some of the protective factors may kick in, or perhaps, or perhaps someone might come home. So there's a lot that can happen that can really reduce risk if we can really remove as many lethal means as possible. We will sometimes use the dieting or healthy eating metaphor. Don't love to do this with kids with disordered eating or eating disorders, but really the idea that if you are really trying to avoid chocolate and you have a bunch of chocolate in your home, it is going to be incredibly possible to not eat the chocolate. So removing the chocolate from this home, or in this case, removing the lethal means, can really reduce the likelihood that they engage in that behavior. We review the restriction to lethal means separately with the adolescent and parent. Essentially, what we're doing with the teen is we're asking them if they have anything hidden away or if they're keeping anything just in case to end their own life or to use to self-harm. Versus with the teen, versus with the parent, we are going over a very thorough list of what lethal means need to be removed. Again, there is a contagious component to non-suicidal self-injury and self-harm. So we're really hoping to avoid these by not discussing it with the teens directly. And continuing to assess access to lethal means throughout the time that you're seeing the teenager. As teens start to get better, or for various reasons, there's an amount of drift. What I mean for that is parents and families may start out very, very strict and have locked away absolutely everything, the kitchen knives, the medications, the Tylenol, all the ropes in their house. And as time, if their teen is doing better, or if they're just getting more comfortable with the idea, they may naturally start to, well, we really need the kitchen knives for cooking, so maybe we can just leave out this one kitchen knife. Or my daughter is really sick this week, and they're having headaches, so maybe I'll just leave out this bottle of Tylenol. And so really assessing it throughout treatment to make sure that everything is being continuously removed is important. So removing particularly guns, sharps, pills, both over-the-counter medication as well as prescription medication, alcohol, any household poisons like bleach or like cleaning materials, or additional means, and really looking at methods such as jumping into traffic or jumping in front of a train need to be addressed via close monitoring. So that is an issue we have here in the Bay Area. We live next to a lot of train tracks, and so oftentimes if a child lives close to the train or passes a train on their way to school, we really have to sort of couple that with close monitoring, so the family members really closely going with the child to the train station. And removal is always preferable to locking or hiding. So sometimes parents do not have access to somewhere to lock away. Some feel like it's too difficult to remove things, so they choose to lock it away or hide it. So particularly for things like firearms, if there is a gun in the home, we do not recommend simply locking away that gun. We really recommend it being fully removed from the home, just because it's a severely lethal method. And sort of removing anything you don't need as far as medications or anything you don't need on a daily from your home to a friend's home, to a family member's home, and then locking away what you do maybe need day to day, like kitchen knives or your headache medication or whatever it is, so the teen cannot access it. Really, what I do not recommend to parents is hiding these things. I will have parents say to me, we have a really large house, there's a lot of places to hide things. And I will tell you, it's really hard to watch the kids all the time, and they will find things. So really trying to remove them or lock them away is preferable to hiding lethal means. So I just wanted to zoom out a little bit and really talk about why is this important. So when do people take their own lives? Well, among the people who nearly died in a suicide attempt, 24% that said that less than 5 minutes elapsed between the time that they decided to make they decided on suicide and the time they made the attempt. 5 minutes. So I really hope this drives home the point about removal of lethal means, is that we really are, if we can add sort of 1 more minute, 2 more minutes, any amount of time onto this, it can really reduce the likelihood that these individuals act. And how do young suicide victims get a gun? Well, 85% of youths under 18 who died by suicide by using a firearm used a family member's gun, usually a parent's. And so this is why we talk about really removing the gun from the home, not simply locking it away. So speaking of parents, working with parents is incredibly important, and we are having parents do a lot of monitoring with the teen. We are working with the parents to make sure that this monitoring isn't too intrusive. So if you heard me talking about the need for close monitoring and went, Anya, I don't even understand, like you're saying that there needs to not be family conflict in the home, but you're also saying that the parents need to monitor these teens closely. How can both of those things be true at the same time? Well, I'm here to tell you they can, and we're really like staggering the supervision depending on the level of risk. And we're working with parents that when they're monitoring their teen, they're not peppering them with a million questions about what's going on in their life or yelling at them or doing something else, that they're really there to keep sort of an eye on the teenager and not engaging in any behaviors that might be really high in conflict with the teen. But monitoring can look really different. It might look as small as frequent check-ins or open or unlocked doors or not allowing the adolescent to be alone, to being much more severe, like chaperoning the teen whenever they leave the home or monitoring them 24/7, such as not allowing the adolescent to be alone at all, like sleeping in the same room or bed with them at night. And this may not be sustainable. We never recommend parents do like very close monitoring or 24/7 monitoring for an extended period of time. This is incredibly stressful on parents. I do not expect them to be doing this for months at a time. Really, this is supposed to be sort of just for the extent of time that this teen is in crisis and may, and as the crisis resolves, parents can sort of reduce monitoring, or we may decide actually the crisis is not resolving and this child or teen needs inpatient level of care where they can be monitored more effectively. So really, it's just that level of monitoring until the patient can be assessed by a mental health provider. So creating a safety plan. So yes, parents are doing a lot of monitoring, but we're not leaving it all up to the parents. We're doing a lot of work with the teens to support them as well. So we are going through a safety plan and create a safety plan with the youth. So we will sort of identify warning signs for the teenager, like what is coming up for you when you are in crisis. Are you, what are some of the warning signs for you? And we'll often use a feelings thermometer to help teens kind of get this sense. And really for us, warning signs are, where are you in the 8, 9, 10 range? What are you noticing for yourselves? Are you noticing you're getting really irritable or agitated? Are you noticing that you are finding yourself, really isolating? Are you noticing you're crying a lot? Do you notice you're getting numb? For you, what is the sign you're going into that really dangerous zone? And we create a safety plan, which you'll see on the next slide with, we also will do other safety interventions like creating a hope box, which you guys will see, and teaching basic CBT and DBT coping strategies such as distract, self-soothe, improve the moment, and tip, which have been found to be very successful in reducing self-harm and suicidality. So creating a written safety plan is considered to be a best practice for suicide prevention. And so I just want to walk you through how you actually create a safety plan. So this is the standard safety plan that we use here at Stanford and that many individuals use. Sort of you have the picture version on the right hand on the side, and on the left hand of the slide, you have the physical text. So as I mentioned, those warning signs. So what is coming up for you? What are thoughts, behaviors, situations, feelings that may give you the sense that like a crisis is developing and you might be like going into a period where you'd actually consider acting on suicide or self-harm? Then what are some coping strategies? What are things that have helped you in the past, both internal coping strategies like distracting yourself or using deep breathing or a relaxation technique, or talking to a friend or listening to your favorite song? What do you do that helps you in those moments to feel better? Don't worry, we're also teaching them some new coping strategies, because oftentimes if they're in this position, they may not have effective coping strategies, and that's where we come in. And then number 3, what are people and social settings that can provide you distraction? So here is typically where the teens are naming sort of friends they can go to, or other people in their life that they can go to for a distraction. I want to be really clear. This is not people that they can go to for help. We are not encouraging teens to go to their friends and tell their friends all about their suicidal thoughts or self-harm thoughts. We're really encouraging them. This is not somebody you have to go to talk about this problem specifically. This is somebody that when you're in distress can help provide you a distraction. Is it someone that can log online and watch a movie with you, talk to you on the phone, play a game with you, like just someone that can help provide you for distraction. In step 4, that's when we're naming people that can help you. So really we are having the teen name adults in their life that can help them. So typically this is mom, dad, grandma, grandpa, aunt, uncle, older brother and sister that's over 18 that can really provide help in an emergency. And then we'll also list professional agencies so that if they do have a therapist or a psychiatrist, those people will go on there. And this is also where we will list sort of crisis hotline numbers. So I have listed, I have not used it, although I know some mental health professionals that have tried it out, but I believe in Ukraine, the main sort of suicide hotline is Lifeline Ukraine. You can sort of, I believe, text 733-733. You can go on their website and you can reach out to them, I believe, on multiple platforms, Discord, Telegram, Instagram. They have several different ways to contact you, as well as chat lines online and chat lines and phone lines. So for if you are in Ukraine, this is the one I would recommend. If you are in the US, we have 988, which is a new suicide number that you can call. And then we have some Bay Area specific crisis lines listed on the right-hand side over here. We speak with the families about what can be done in the environment to make their environment safe. So teens in this spot will typically mean things like removing the means. Often teens will name this themselves because they can recognize like, hey, seeing the knives in the kitchen actually really triggers me and distresses me and makes me feel like I want to self-harm, or like I need like loud noises really distress me, or I need there to be not be conflict in the home. And as we mentioned earlier, protective factors are super important. So we're definitely thinking about what can make their life worth living. What is important to them? Is it their cat? Is it their parent? Is it their future? What is really making their life worth living? And thank you. I see Donna. It's a safety clear. So this is just another plug for this website. Okay. So for the sake of time, I'm going to skip this slide, but I just want to go over that there has been a lot of research on using the safety plan predominantly with adults and veterans in the United States, but that it was very, very effective in reducing suicide attempts and self-harm, and it actually resulted in 45% fewer suicidal behaviors. So I really want to spend some time going over the Hope Box. This is something we do in the ASAP clinic here at Stanford. And I think it's, and I do it in my DBT clinic, and I think it's really, really wonderful. So as I mentioned, oftentimes it is really difficult to find coping skills or reasons to live in a crisis, because when you are sort of that 7, 8, 9, 10 out of 10 on the feelings thermometer, it can really be difficult to think in that moment, what can I use to actually help calm myself down? So that's where the Hope Box comes in. It's a container that combines both items that they can use to help regulate their mood, so coping items, as well as reminders of what makes their life worth living. So this can include photographs of their favorite people, places, postcards of places they want to visit, paper and colored pencils to draw, letters from their friends, gifts. It can also include like puzzles to do or things to self-soothe with, such as, different fidgets. Here's a fidget I like to keep, or different self-soothing items. And we really encourage the teens to create it in a box or a bag, something that they can bring around with them wherever they are, whenever they are. So they are, very close to some items that they can use to help regulate mood. And we teach the teen about this, and we really help them find a place they can easily access it. Here's one example of a sort of sometimes called self-soothe boxes or a hope box. So you will include like books that make them happy, journals, things to color with, maybe their favorite movies. I think what this picture doesn't include is we do like them to have them include pictures of their family or friends or their pets, whatever makes their life worth living, as sort of those reminders of the protective factors. Okay. So the hope box and the safety plan are two major safety interventions that we do, as well as speaking with the families about the removal of lethal means and close monitoring. The other things we do across these up to 4 sessions in ASAP Clinic is help teach the teens skills. So that's what I'm going to spend the next few minutes talking about. So we are a DBT informed intervention. So we are teaching mostly DBT distress tolerance skills. There are a few main ones that we've chosen to teach in this intervention, as usually they're the ones that work the fastest. So the first you may likely have heard of, it's sort of the bread and butter of DBT. It is the TIP skill. It stands for temperature, intense exercise, paced breathing, paired breathing with progressive muscle relaxation. In Russian, there is Russian translations of all of these skills. They should be included in your slide, but it translates to trud. If anybody would like to teach it in Russian, I'm not really sure exactly what the Ukrainian translation is. Unfortunately, I have not been able to find Ukrainian versions of the slides, but I know the Ukrainian slides should have translated this for you guys. So really the idea here is that T stands for temperature, temperatura, and really you are looking to tip your body's chemistry by triggering the dive reflex that all mammals have, by really putting cold water on, sort of covering your eyes. So the best way to do this is to take a bowl of water and ice, and put your whole face in it, holding your breath and dunking yourself for about 30 seconds. And really what this does is it triggers your parasympathetic nervous system, your relax system. It helps to drop blood pressure and reduce heart rate. I should mention that these are not safe with people with heart conditions, but otherwise, or blood pressure conditions, but otherwise safe for anyone else. Then we have, intense exercise. So really the idea that engaging in intense exercise for a short period of time, such as running in place or playing basketball, up to about 20 minutes, but really any amount of time that gets your heart and blood rate pumping. And initially your heart rate will go up and then it will drop. And so really having this ability really helps physically relax the body. We have paced breathings, which many of you may have heard of. There's a lot of different paced breathing sort of topics out there in psychology between, some of you may have heard of square breathing or things like that in DBT. And really what the research has shown that the most effective form of breathing that reduces, relaxes you and increases your parasympathetic nervous system is when you breathe out for longer than you breathe in. So making sure that if you're breathing in or inhaling for a count of 3 or 4, that you're exhaling for a count of 5 or 6. So really that long out breath is the part that works. And paired muscle relaxation and deep breathing is really the idea that you are exhaling or saying relax as you are tensing and releasing muscles. I will often encourage families to look up progressive muscle relaxation on YouTube or on the internet, because there are a lot of great short and long videos, and I will practice this in session with them. for time, I'm just going to keep going through this. The other distress tolerance technique that is incredibly important and really, really useful for teens, and I think the one that they use the most, maybe sometimes even overuse, is the idea of distraction. So really distracting with a wide level of activities, from just renting a movie, watching TV, going online, to doing things, contributing, or pomagać kamuta, and really finding volunteer work, sending a text message to your friend that says, hey, how you doing? Saying something nice to someone. The act of helping someone else actually really improves mood. I will say the comparisons one does not work for everyone. So if this is not one that works for your teens, that's okay. But comparing either yourself to people that are having a harder time, or yourself to yourself in a time you were having more difficulties. Or trying to create different emotions. So we know if we can change just one part of an emotional component, we can shift the whole emotion. So if you were feeling sad, you don't have to watch a funny comedy, although you can also watch something scary in order to shift that emotion. Pushing away, so really doing something to sort of put the pain on a shelf for a moment and walk away from it. Just sort of very tactical, very planned avoidance for a short period of time. Changing our thoughts by doing something that completely engulfs our mind, like working on a puzzle or a word search or something like that, or doing homework, or practicing a new language, which I do all the time. Or sensations, so trying to change the physical sensations in your body to help calm you down. So taking a hot or cold shower. Sometimes people will think that taking a cold shower is like tip for temperature. However, it is not, because really the cold has to be on your eyes. So dunking your head into the cold water or using an ice pack on your eyes is much more effective. If you're taking a cold shower or like a warm bath, that's much more, that can help reduce suicidality or self-harm, but that's much more in this like distraction. It helps sort of change the sensations. Or it's a little bit of self-soothe too. So another way we can change our emotions is by really going through our 5 senses. So really using our 5 senses to help us relax or calm down. So using our vision by looking at our favorite things, like watching a sunset, or picking a beautiful flower, are some examples, or watching your favorite show, really looking at your animal and describing all their colors, listening to music, or listening to your favorite sounds, listening to the sounds of ocean, doing anything with hearing to calm yourself down. Using smells, so smelling your favorite scent, your favorite food, using like hand lotions that you find are really nice for you to really focus your entire mind on the sense in order to relax. There's taste, so eating your favorite food, or anything that's your favorite taste to help calm down. Or touch. So touch can be a lot of different things. Petting an animal is my favorite one, so that's the one I'm going to keep bringing up. But it can also be like noticing the wind on your face. That's one I really like. Noticing the temperature in a room, things like that. And finally, the last one we teach is improve the moment. So ulichatamamiento. So basically in this is something you can sort of typically do mentally with not a lot of people noticing you're doing this to improve your mood. You can use imagery, like imagining relaxing scenes. You can find a purpose and meaning in what's difficult and what's going on, sort of finding the silver lining. You can use prayer, whether or not you're religious, or praying to the universe, or just to the earth, or whatever, however feels best to you. You can do anything that's relaxing. So breathing deeply, changing your facial expression to a smile can actually really change your mood. Drinking something relaxing, taking a hot bath, which is my favorite. Really one thing at a time, focusing at one thing at a time. So just doing one thing and not kind of trying to split your attention. Either taking a brief vacation, like literally going away, or actually just planning a vacation for yourself, or just going into your bed and taking like a little break to relax. What's important is that this is brief. You don't want to take it. You don't want to do this for days, because that avoidance may make things worse. And finally, encouragement. So thinking encouraging phrases or cheerleading phrases to yourself, like things will get better. All right. So I'm going to skip this because we've talked about it a lot. It's really important to work closely with parents to make sure they are monitoring their teen, but also that they are taking all talk about suicide seriously and maybe not having judgments like the child is trying to manipulate me. We really talk to parents about it's better to be safe and take your child seriously than sorry. So that's what I just said here. But also it's important to really decrease the family conflict and maintain a positive relationship with their teen. We know that family conflict is one of the biggest factors that contributes to suicidality and self-harm among teenagers. So we really work with the parents to increase validation or support. We will sometimes, if we have time, do something called the family positives intervention, where the youth identifies 3 positive things about him or herself, and the parent identifies 3 positive things about the teen as well to sort of improve communication within the home. And then finally, just briefly want to talk about reducing suicidal contagion. I know I'm a bit over time and we have questions, but reducing contagion is incredibly important within a teenager's family or peer group. So seeing media reports of suicide, for example, or knowing someone that has ended their own life, either directly or indirectly, really increases the likelihood that a teen may act on suicide. So this is really important with social media, especially with the rise of new social medias like Discord and TikTok. There are more and more ways for teens to share ideas about how to self-harm or share ideas about suicide online. So for parents for you to have this conversation directly with the teen so they know that it is contagious and it may be harmful for them if they're watching a lot of videos like this. And for parents to understand that that there is a contagious factor so that they can limit the teen's conversation with their friends if they are discussing self-harm or suicidality. I'm going to skip this. Maybe what I would like to say on hospitalization is, while sometimes it is absolutely necessary to hospitalize a teenager, if there's no way to work with the family to provide monitoring or other things, obviously the first thing we want to do is keep the teens safe. I work in a dialectical behavior therapy program, so we have a lot more options around monitoring. I just want to note that sometimes for some teens, hospitalization can be really impactful because it can really, they can learn new behaviors from other teens. And we know there's a high risk for suicide directly after hospitalization, and there's no data to actually support that hospitalization reduces risk in the long run. However, if you are a therapist working on your own and you have a suicidal teen and you are not comfortable that you can keep this teen safe, please by all means hospitalize them. And important things to consider are, is the parent able to provide monitoring? Is there a lot of conflict in the home? Are they able to remove all lethal means? Is the client committed to trying skills instead of, attempting to end their own life? Is there a good relationship between yourself and the therapist? So just a brief shout out. This is not related to our department here at Stanford, but it is just a volunteer service that I am a part of called Telehelp Ukraine. We do not deal with suicidality, but we are a service that provides mental health consultation and support to individuals in Ukraine. So we are sort of one-off, sometimes several sessions with individuals to provide, some psychoeducation on mental health issues, provide basic coping skills, things like that. So I encourage, if you have not heard of it, to look us up. Again, this is not affiliated with Stanford directly. It's just a volunteer service that I am a part of, that I've been working with in Ukraine. All right, so that brings us to the end of the talk, and I'm happy to take any questions.
Very good. Thank you very much for this very informative lecture. I always learn when I hear other faculty members presenting, and it's a good reminder about things that I've learned in the past. So we have few questions, but before we get to the first question, there was an inquiry whether we can provide the CEs for this lecture or the other lecture. Unfortunately not. Putting all this through the system to get continuous education is complicated at Stanford. And usually the focus is more on continuous medical education, not about general continuous education. Sorry about that. Okay.
Great. I'm seeing a lot of the questions in the Q&A come in.
Very good. So is it possible for a teenager who is injuring themselves, himself or herself, not to know why they are doing so?
This is a great question. Yes, I think it is definitely possible for them not to know. I think that this is less that they don't know, and often teenagers are sort of maybe avoiding the emotions or thoughts related to the self-harm or the self-injury. And sometimes certain non-injurious behaviors can be driven by things that are not suicidality or self-harm, be driven by, like, let's say OCD or other sort of impulsive behaviors. But usually as part of our assessment, we're very careful in helping sort of the teens figure out sort of step by step what happened. So that's part of the role, is that we are going step by step to sort of figure out, okay, so this happened first and then this happened and then you had this thought, and really after having the thought, like, no one cares anyways, that's when you decided to self-harm. So that's part of the job of the mental health therapist, is to help the teen figure it out. Teens that are self-harming are really avoidant to emotion, so oftentimes they're not discussing it directly.
Yeah. And sometimes some teenagers might not be aware, might not have insights in the beginning, but as they are exploring the feelings or the thoughts that's leading to the behavior, that might learn about it. So I've noticed that with some teenagers, it takes them sometimes to be able to get to the bottom of what's precipitating these feelings and these thoughts. Okay.
Yes, exactly. Yeah.
Thank you. A question about whether we are aware of any LGBTQ groups for use from Ukraine.
Yeah, and non-binary youth from Ukraine. I'm not aware of any LGBTQ support groups directly in Ukraine. I don't know if any of our other Ukrainian providers or any of our Ukrainian providers, people on here, are aware of them. There are a lot of online programs, and you know, I would look into things like the Family Acceptance Project out of SF State or the Trevor Project for some additional resources. Yeah.
Question, thoughts about suicidality in autistic individuals. Any thoughts about that?
Yeah, I wonder, Antonio, do you have any thoughts about that? Because you are the expert in autism more than I am. So maybe I'll let you start there and I can jump in.
Sure. I think we have to be mindful about the level of functioning of the individual first. What their mental age. For example, like I worked with adolescents with autism who have limited cognitive abilities, and they were not aware of the consequences of their suicidal ideation, and more specifically their suicidal gestures. This was a case when the individual attempted suicide and they thought that nothing will happen to them. In case they die, they would still relive and will recover from that. So they didn't see the finality of death at their cognitive level. So that's something to assess with that. Now, the high functioning individuals, the people who are verbal with the cognitive functioning within the average range, I think the management is very similar to what you would expect in typically developing individual with suicidal ideation. So, you know, the safety planning, the triggers, safe proofing the house, you know, discussing the relationship with the precipitant. So all of these will be can be applied. And on the inpatient unit, we have several individuals who are on the high functioning end of the spectrum who were admitted, and most of the intervention that were used for are being used for the typically developing adolescents with suicidal ideation are used with this group. So that's important. There should be some tweaking with regard to the triggers, because triggers for individuals with autism might be a little bit different than typically developing individual. Like if there is sensory to sensitivity, so you have to be mindful of that and try to minimize that as much as possible. Sometimes part of the interpersonal complex is the awareness that the individual is different than their peers, and trying to accept that, and the fact that they're going to be different for the rest of their lives. So that's one of the challenges that we see sometimes with adolescents with suicide and the history of autism. So these are like a few thoughts about that.
Yeah, certainly completely agree with you, Dr. Hardin. And I think, for those that are high functioning, continuing to teach them skills, or many of the skills can be adapted. If there is the ability to sort of notice the triggers before they occur or as they're coming on, using distress tolerance skills.
Very good. Thank you. The next question is how to distinguish suicidal thoughts that are associated with sadness or depression, or better, in terms of how to assess whether the depression is associated with suicidal thoughts or not. If somebody's sad or they have depression, sometimes they have suicidal thoughts. How do you assess the severity of suicidal thoughts?
Yeah, I think that's a good question. So I think that if someone is expressing any suicidal ideation, passive or active, regardless of whether or not it's sort of due to depression or another factor, it's really important to assess suicide. So for me, what I'm looking out for is the suicidality passive? So it's more just, and we'll see this in more common in when it's depression based, that they're just thinking more generally about death and dying, or they may just want to go to sleep and not wake up, or they just don't want to do life anymore, or they feel like they'd be better off dead, versus an active suicidality, which is that they are expressing life is so miserable, I cannot stand it anymore, I want to end my own life. And then being very careful to assess, is there intent to follow through with the suicidal ideation? Is there a plan in place? Have they started taking preparatory acts towards suicide, like looking up methods they could end their own life with?
Very good. Thank you. A question that's translated from Russian: what's a good DBT instrument to use if there is such thing?
Yeah, so I mean, DBT is a whole package program. The things I shared with you today are sort of DBT informed, but specific to suicide and self-harm. While we know the most effective thing is to do the whole package of DBT, I would really recommend teaching some of the distress tolerance skills that I discussed at the end of this talk. So specifically TIP, distract, and self-soothe are really, really effective. I like, with my own patients, I really encourage them to try TIP first, as that is often the one that will be the fastest, and it gives really a physiological change.
Very good. Last question is regarding the impulsivity as a risk factor. If you can talk a little bit about it in general, but also as it's related to girls with ASD, ADHD, and suicidal risk.
Yeah, so I will, I don't know the exact data on ADHD and suicidal risk. I will talk sort of from a clinical perspective. This is something we talk about a lot because individuals with ADHD do have increased impulsivity. So, making sure to take a combination approach, and are they on medication to really manage the impulsivity and hyperactive and other symptoms related with their ADHD. Really thinking about how that might impact some of the prompting events, especially with individuals with ADHD. And as Dr. Hardin was talking about, sometimes with ASD, there's a lot of rejection sensitivity, or this understanding that you're different. So really working with the teens to really figure that out. I think this is much more insidious in girls sometimes because there's an underdiagnosis of ADHD in females. And so sometimes they're really struggling at school or with a lot of these things, and it's just not noticed. And that can really contribute to feelings of hopelessness. So really doing a careful assessment and making sure that the other mental health disorders are being treated also.
Very good. I think we have one more question. I think hopefully someone will be able to translate it. But while waiting for the translation, can you comment a little bit on impulsivity that's related to ADHD versus impulsivity that's related to character organization and personality organization?
Oh, that's a really good question.
I
I think it's I think it's really challenging with teenagers, particularly. I think really much more than the impulsivity, I'll see like the problem solving challenges related to like character organization. Oftentimes, if there's like a not well-formed character organization, or they don't really have a sense of self, there's more problem solving challenges. The impulsivity is really around the problem solving challenges, this belief that nothing is ever going to get better, this real sense of hopelessness. They're not able to consider other problems or other ways to solve the problem. And they're then more driven to act on the self-harm or suicidality. I think the impulsivity with ADHD is much more, there's just a higher level of reactivity. So they may they may go from a baseline emotion of like anger at like a 10 to 100 very, very fast. And so if they have something in their vicinity, they're more likely to grab it and use it for self-harm.
Very good. Thank you. Now, question, and this probably will be our last question, is the youngest age of a child with suicidal ideation and suicidal risk?
Okay, so I specifically treat teenagers. So the youngest kids we've seen in our ASAP clinic, I believe, was a 10-year-old, 10 or 11-year-old. However, suicide risk does not know an age. There are young children, as I'm sure Dr. Hardin can speak to, on the inpatient unit. I believe our inpatient unit only takes like 13 and over, but other suicide inpatient units take as young as 5 or 6. What I spoke with about younger, I don't think that there's ever too young an age to be concerned about this. I think what you're really looking for, and particularly the young kids, 5, 6, 7 years old, was this question of intent. So a child that is 5 or 6 may not have, and this is to Dr. Hardin's point earlier with ASD, may not have the awareness of what those behaviors are permanent or forever. And if they have intent, it's really really important to assess. So that kid may jump off like, a couch and think that is a legitimate way to end their own life, and they may not understand the permanence of this. And that doesn't mean that the suicide risk actually isn't very scary or greater, because they may just be taking some multivitamins or jumping off a couch today, but as they age or tomorrow, they may try their roof or something else. So really, if a child at any age is expressing a want to not live or an intent to end their own life, I would take it seriously.
Yeah, so unfortunately, there is no lower age limit for suicidal ideations and attempts, and we don't have an inpatient unit here, but in a previous job, we had an inpatient unit for kids, and we were seeing kids as young as 5, 6 who would be admitted for suicidal statements and suicidal attempt. As we discussed, the question is whether they know all the different components of death. I recall a patient that who was suicidal, but they were worried what would they need with them after they die, how they're gonna eat if they die. So they didn't know a little bit, they didn't understand the concept of death. And like the example that you gave with regard to jumping off a couch, and they think that's gonna be enough for them to die. That speaks a little bit about their cognitive limitation at a certain age. Sometimes it has a protective factor, but sometimes, unfortunately, it is risky because I might do something that might not understand the consequence. So that's something to keep in mind in the young age group. It's definitely less frequent than in the adolescents, but has been reported, and some of it might be a little bit of contamination. The kid, when they're upset, they might express passive wishes of death because they've heard somebody making statements like this. Okay. Very good. The question is the assessment of depression in patients who are young.
So
Okay.
depression is more exceedingly rare prior to puberty. So it's not that we never see it before puberty, but as we definitely do. I see it all the time, but we see it much rarer sort of before children hit puberty. I think for me, what I see more common is less like depressed mood as we think about it with adults, or crying, and a lot more irritability or aggression or anger or frustration. I actually do know the data on the second question. So there's another
Very
question.
good. Yeah, go ahead. Yeah,
Answer our last question, which is, what are your thoughts regarding suicide attempts and gender? And do you think the data from former USSR countries is significantly different from the data in the US? So we know that women have higher rates of attempting suicide, and men have much higher rates of completing suicide, usually because there's a difference in the means used. So men are more likely to use much more lethal means. And as far as the countries from the former USSR versus the US, we know that suicidal risk is actually much higher in countries from the former Soviet Union than it is in the United States. Actually, that is true for most mental health illnesses. So the predominance of mental illness in countries from the former FSU is hovering at about 20% by some estimates, versus it is, around 10% here in the United States. I wrote an entire dissertation, so I could talk about this topic forever, but it has a lot to do with just like a lot of transgenerational trauma, exposure to war, and a lot of the tactics that the former Soviet Union used to control political dissonance. And it looked like Donna had maybe a comment on that as well, if she wanted to jump in.
I was
Okay.
just thinking, do you want to translate the last questions, or you good on Russian?
Yeah, if you can do it orally, that will be good.
Orally? Okay. So some adults has idea regarding reincarnation after the death, to be born as normal. I think it's related to autistic adults. Do you have any advice regarding this case? In our country, it's a lot of problems among autistic adults. Is nobody accepting them to the work on social?
So I wonder if Dr. Hardin wants to jump in. I will jump in and say that, I think there's a lot of different ways to address this. I don't want to be at direct opposition with people's religion. And, a big part of DBT in these skills is sort of playing devil's advocate. So I will often really directly ask them, but do we know that people are actually reincarnated? Because last I checked, no one has ever died and come back and told us what happened. So, and I actually use this with teens a lot, because their thing is not that they're wanting to be reincarnated as normal, but they feel that when they die, it will be this painless state of nothingness. And I really like to challenge that belief, because while I may not personally hold that religious belief or otherwise, the facts of the situation is that we don't know. No one knows. And sometimes if we can sort of create any doubt in this sort of idea, it can really shift them to not engaging in suicide.
Yeah, one important thing based on this question is it serves as a reminder that when we assess teenagers or adults for any psychiatric or medical condition, is to ask about their religious beliefs and their spirituality. And this is maybe on one side is to try to challenge them, but more importantly to assess the risk. Because if the individual believe that if they commit suicide then they will die, but they're going to come back, that means that their suicidal risk is much higher than someone who believe that when they're dead. So anyway, so that's important to keep in mind, and I will look at it more as a factor or a variable to keep in mind when assessing the seriousness of the severity of the suicidal ideation, you know, whether you can be successful in challenging them or not, that's a different topic, but that's gonna make me a little bit more anxious about the risk that this individual is exhibiting, and maybe a little bit be more on the safe side with regard to maybe closer monitoring or recommending hospitalization. Very good.
And getting them involved in like just a society or an environment that is accepting to them, because I do want to address that second half of the question, is that the society is really not accepting them. And a big part of, you know, from DBT theory is having that level of validation or feeling understood by your environment to decrease the likelihood of extreme behavior. So like, yes, the society on the whole may not accept them. And I'm sure there are groups of other, you know, not neurodivergent individuals or family members that getting them as part of a support group so that they feel understood or accepted somewhere would be important, or something I would be looking to do.
Very good. Thank you, everyone. And more importantly, thank you, Dr. Atasuntseva, for this great and informative lecture. And as you can see, there are a lot of questions, and probably if we had additional time, there will be more questions. So thank you. And I want to thank Irina and Dimitri for their interpretation of this session. Thank you, everyone, and we will see you next time.
Спасибо, до свидания всем.